Hi everyone, I'm Joanne Tropea and I'm going to be talking about the Improving Palliative Care Education and Training Using Simulation in Dementia study that was a big part of my PhD. I'd like to start by acknowledging all those involved in the project and the funding providers. So today I'll give some background to the project, talk through the research aims and methods, and the main findings of the implementation evaluation, as well as the strengths and limitations, and finally some conclusions. So just a bit of background. In Australia, we've got just under 200,000 people living permanently in residential aged care, and we know that over half of them have a diagnosis of dementia. So residential aged care, it's a key provider of palliative and end-of-life care to people with dementia. And what we mean by a palliative care approach is one that focuses on the quality of life for the person living with the terminal condition, so the person with dementia, as well as their families. The focus is also very much on prevention and relief from suffering, so management of pain and other physical symptoms, as well as ensuring their psychosocial and spiritual needs are met. So people with advanced dementia have specific palliative care needs, and there's a growing body of literature supporting this. And it's for a number of reasons. The trajectory is often unpredictable, and so it can be difficult to recognise when a person with dementia is nearing the end of life. In the advanced stages, the person has their verbal communication quite severely impaired, as well as their decision-making capacity. And so it can be challenging to manage symptoms that traditionally rely on verbal self-report, such as pain management. Also, it means we have to rely on family or support people to convey the person's preferences and end-of-life wishes when there's no advanced care planning in place. And this can lead to carer burden. There's several studies that show people with dementia receive suboptimal end-of-life care, and the findings, the final report, of the Royal Commission also found this as well. So there's reports of poor symptom management, including poor pain management, lack of advanced care or goal-directed planning, which means decisions are often made in the immediacy or crisis situation, and can lead to some inappropriate treatments and transfers to hospital. There's also been reports of poor communication between care providers and family. The Royal Commission, as well as other international bodies, have called for direct care staff to receive further training and education to upskill them to improve the quality of care. And that's what IMPETUS-D aim to do, improve the quality of care through staff training. So IMPETUS-D is a screen-based simulation training program designed to improve end-of-life care for people with advanced dementia living in residential care. So this slide shows the landing page for personal carers of the e-learning platform. The modules were made up of, there were core modules and then recommended modules. So the core modules were modules that we wanted staff to do as a minimum, and there were 5 for personal carers and 3 for nurses, the targeted nurses. But all staff had access to the 11 modules. Another thing to mention is the modules were developed by experts in simulation and reflect common scenarios. They're immersive, they include videos and images filmed in a real aged care home, and designed to stimulate learning and practice. For example, a number of the modules ask the learners, what would you say, what would you do? So the research aims, we wanted to assess the effectiveness of IMPETUS-D on a number of outcomes using a multi-site cluster randomised controlled trial design. So the outcome measures we were interested in, the primary one being transfers to or deaths in hospital within 6 months. Uptake of goals of care plans. There were a couple of modules for nursing staff to do that focused on having goals of care discussions and documenting goals of care plans. Also interested in measuring change in staff knowledge and attitudes about palliative dementia care, and we used an existing survey called the QPAD for this. The brief family satisfaction with end-of-life care was also of interest, and we used an existing instrument for that as well. And there was a process evaluation conducted alongside the trial where we explored implementation, staff participant experience and barriers to participation and other implementation processes of the training intervention. There were 3 phases in the study design. The pre-implementation phase where we developed the training program and recruited care homes and randomised them. So all care homes were part of a single for-profit aged care provider, and they were based in Melbourne, Adelaide and Sydney. 12 care homes were randomised into the intervention group where they received IMPETUS-D, and 12 were controls where they had access to the usual training opportunities. We collected baseline data to make sure the staff characteristics and the resident characteristics of the 2 groups were similar, and they were. Then at 6 months, following the pre-implementation, there was an implementation phase where we actively promoted the online training, but we soon learned that staff actually prefer to learn face-to-face and at work rather than online in their own time. It's sort of individual learning. So we ended up holding facilitated sessions at each of the care homes. Post-implementation phase was once that implementation phase was over, we then collected the outcome and implementation data, including barriers to staff participation and other measures there. And we did this through surveys and focus groups. Okay, so the main findings, there were actually no between group differences in the primary outcome, which was this one here, the hospital transfers at 6 months. No between group differences, and in fact the numbers of hospital transfers were quite low compared to what we'd found in previous studies. Similarly, secondary outcomes, so that the QPAD, the staff knowledge, no between group differences there, and same with the family satisfaction measure, no differences there. When we looked at the implementation processes, in fact, we found the reach was suboptimal, so 26% of staff completed at least 1 module, and of the core modules, the dose, only 4% of staff completed their core modules, and we were aiming for 80% reach and 50% of nurses to do the core modules, so certainly didn't reach the levels that we were hoping for. When we asked staff about their experiences, so this was through interviews and survey items, we received mainly positive feedback. Most agreed or strongly agreed they enjoyed the module, felt the information was relevant to their daily work, and would recommend the module to other staff. And then when we asked about barriers to staff participation, we used the consolidated framework for implementation research to not only design the process evaluation and implementation strategies, but also to analyse the implementation findings. We found that most of the barriers related to these 3 constructs of available resources, so staff having the dedicated time, dedicated space to do the training, leadership engagement, so we needed to have leadership not only within exec, where we had the support, but also at each of the care homes. We found care homes that did better than other care homes tended to have general managers who actively supported the program, freed up the time for staff. So there's that interplay as well with the available resources. And then with regards to relative priority, when it came time to implement the training, unfortunately for us, it was around the time that the new aged care standards were being introduced. And these took the activities around that took priority over implementation of IMPETUS-D, of staff participating in the training. Staff needed to do training in preparation for the new standards. The nurses were rewriting care plans, for example. So this took time away from participating in IMPETUS-D. Again, that crossover of available resources and relative priority coming out there. And there's a great quote by one of the general managers there saying it's not about the topic, it's about the load that we had then. So finding the time and finding a little bit more because of the new standards. Some of the other constructs that came out of the interviews and surveys around the intervention characteristics being a barrier. So it was quite complex in terms of we were targeting multiple staff, so the personal carers as well as nurses. And there are 11 modules, some were core, some weren't. It just, I guess, added to the complexity of the intervention that it can be a barrier. And the design itself, it was available on its own learning management system. So some staff reported having login difficulties or technical difficulties that perhaps could have been overcome if we'd put it on the provider's learning management system, but this wasn't possible within the research context. And then finally, staff individual characteristics. So their preferences for learning, they like to learn in groups or at the workplace, not at home, and within work hours. And in fact, I didn't mention before, but we did offer, we paid staff to do the training, so there was that financial incentive, but that wasn't seen as enough. Staff needed the time more so. With regards to the strengths and limitations of the study, some of the strengths include the large multi-site study design. It was rigorous and comprehensive and included mixed methods. The training modules themselves were innovative, simulation enhanced and developed specifically for the purposes of residential care. And it was a real-world study that highlighted some of the sector issues, and some of the issues came out in the Royal Commission as well. Some of the limitations, we did have lower than expected staff participation, and we were unable to establish the true effect of the training intervention. Some of the barriers to participation may have been overcome by perhaps conducting a pilot study, further assessing the usability of the e-learning platform and modules, or more comprehensively assessing them, and potentially integrating the training interventions onto the organisation's e-learning platform may have helped overcome some of those barriers to access and login issues. But this wasn't possible within the research context. And then finally, a more comprehensive assessment of each care home's readiness for implementation. So we could then perhaps target those care homes that are ready for implementation. We had input from general managers, we've got input from exec and from some of the staff, but perhaps getting more input from all levels of staff, as well as families and residents and other stakeholders. So in conclusion, the IMPETUS-D study found no difference in unplanned hospital transfers, that primary outcome we measured, and implementation of the training intervention was challenging and likely didn't achieve adequate staff coverage to really see changes in staff practice or resident outcomes. Future research would be great if we assessed the impact of a more simplified and sustainable version of the training intervention, and also to establish what facilitation strategies might work to increase staff participation in that residential care setting, because much of the research is around studies that are in hospital or primary care. So thank you very much. I'm looking forward to questions. Also, if people are interested in looking at the training program, please do get in touch. It is available now that the study's over.